Thank you, Carol. So I'm going to talk about a trial called the DIVINE trial, which is where this title kind of came from. But first, I'm going to summarize the role of glucose control and outcomes in critically ill patients. And then the last kind of two-thirds of this slide, I'll go through the results of the DIVINE study. As far as conflicts, the only conflict that I have is that the study that I'm going to talk about at the end was funded by Nestle, and they provided all of the formula in it and actually paid us to enroll patients. So overview, studies have found that goal nutrition may not result in the best outcomes. Available data suggests that protein may be more important than non-protein calories. We know that levels of serum glucose affect patient outcomes, and we know that high and low blood glucoses both can have worse outcomes. Here's a little bit of the protein data. This is from Peter Weiss and their group, and this shows you in the panel on the left that energy, an actual 10 to 20% energy deficit from your total required energy, looks like it's associated with decreased mortality, whereas with protein, higher protein is actually associated with decreased mortality. And the cutoff is kind of 1.2 grams per kilo per day in this study that was demonstrated to be associated with lower mortality, specifically in the light blue or the gray blue in patients who are not overfed. If you don't like that representation, here's another way of looking at it. On the left, again, calories, and you can see kind of a U-shaped curve. With the bottom, lowest mortality being in that 60 to 80% of your goal calories, whereas protein mortality kind of is almost linear. As you deliver more protein, mortality goes down. What about serum glucose? Well, hyperglycemia is common in critically ill patients for a number of reasons, one of which is that critical illness actually worsens insulin sensitivity and resistance. Hyperglycemia is associated with the severity of critical illness, so the more critically ill the patients, the more hyperglycemia you'll see, and it's still being teased out, although it's pretty clear that it's probably the cause of worse outcomes. We know the converse is also true, that hypoglycemia is also associated with worse outcomes and looks like it may be the cause of worse outcomes. And in fact, it's not probably just the levels of glucose, but it's actually the variability or the glycemic variability index, which I'll talk about here in a little bit. So here's a study that's actually just now EPUB'd ahead of print that you could see on glycemic variability and its association with outcomes. It's 759 patients, of which 650 survived and 108 died. And when they do some analyses to look at what factors are associated with death, you can see that age and Apache 3 are associated, not a surprise. That's pretty common for all these studies. But glycemic variability is associated in a similar kind of relationship as age and Apache 3 with mortality. You say, well, what is glycemic variability? It was defined in this study as the standard deviation of a patient's glucose measurements divided by their mean glucose times 100. What goes into glycemic variability? Well, age and Apache, so your age has some bearing on how variable your glucose measurements are. So does your severity of illness. We talked about that a couple slides ago. So does the amount of insulin that you get, and then gender, where females are less likely to have glycemic variability than males. So what about the data about hypoglycemia worsening outcomes? So you guys know this trial. This is the NICE sugar trial of 6,000 patients, all with sepsis, 2 different randomized sugar targets. There is a subsequent kind of post hoc analysis of what happens if hypoglycemia ever happened. And this slide shows the severity of hypoglycemia, so moderate and severe hypoglycemia. And in both groups, in the intensive control, glucose is 80 to 110, or the conventional control, which is up to 150. And you could see that in both of those groups, hypoglycemia is associated with worse outcomes, specifically worse mortality. And the more severe the hypoglycemia, the higher the association with outcomes, suggesting a dose response. If you throw everybody together, the other suggestion of a dose response is duration of hypoglycemia. So you can see this divides moderate and severe hypoglycemia into 1 day versus multiple days. The more severe and the longer your hypoglycemia, the bigger the hazard ratio for mortality. So what if we could provide permissive underfeeding with less carbohydrate and adequate levels of protein, specifically whey protein, while we maintain blood glucose control, reduce the risk of hypoglycemia, all with a nutritional formula. So if we just change our nutritional formula and we do this, what does this look like? And that's what we tried to do in this study, the DIVINE study. This study is actually now available EPUB ahead of print in the Journal of Parenteral and Enteral Nutrition. So the objective was to determine whether blood glucose control could be facilitated by using an enteral nutrition formula that contained low carbohydrates, medium chain triglycerides, and very high levels of hydrolyzed whey protein to ensure optimal protein delivery. It's an open-label, multi-center trial at 7 academic medical centers in North America. The plan was to enroll 280 patients to get 160 that were evaluable, meaning they'd completed 5 days of nutrition therapy. And the trial went on for almost 2 years. Who did we include? We included mechanically ventilated, critically ill, obese, and overweight, meaning you had a BMI, a body mass index, between 26 and 45, and you were thought to require enteral nutrition for at least 5 days. We excluded patients with hepatic failure if they were a trauma admission or they were either from major surgery or about to have major surgery, if you were pregnant, if you had type 1 diabetes, burns, or were unable to receive enteral nutrition. The control group was a high-protein formula, and the experimental group was a very high-protein formula with low carbohydrates. Specifically, and these were both commercially available, the control formula listed in the kind of middle column has a caloric density of 1, which so does the interventional formula, but it has a little bit lower protein, higher carbohydrate, and similar amount of fat as the experimental protein. And the goal in both of the groups was to try and deliver 1.5 grams per kilo of ideal body weight of protein per day, and I'll show you how we did in that. The endpoint was the rate of glycemic events outside of the interval of 6.1 to 8.3 millimoles per liter in the first 7 ICU days, with a bunch of secondary endpoints, serial blood glucose levels, markers of nutritional status, et cetera, that you can read up there, including clinical outcomes, although we were not powered to detect differences in clinical outcomes. So here are the results. So 105 patients were actually randomized before this was stopped by the DSMB. It was stopped from the DSMB because of some concern over low blood sugars that I'll show you as we go through these results. Of those 105 patients, 102 patients had glucose measurements that allowed them to be included in the intention to treat analysis. I still find this amazing that there were 3 patients that met the inclusion criteria that didn't have glucose measurements, but it is true. It did happen. Here's what they look like. In general, they're standard critically ill patients, non-surgical, because remember we excluded surgical. They are similar between the two groups in the control and the experimental group. The experimental group did receive significantly fewer calories. That was by intent. Both groups received similar amounts of protein, and the experimental group received less carbohydrates, and that was the makeup for the fewer calories that they were getting. And this is actually the amount delivered. So in energy, the control group got 18.2 kilocalories per kilo compared to 12.5 in the experimental group. Both got about 1.2 grams per kilo of protein. We were targeting 1.5, remember. In carbohydrates, the experimental group got about half as much carbohydrate as the control group, and fat was similar between the two. Here's what those look like again. Protein is on the left, and you can see it's about 1.2 grams per kilo per day. Energy is on the right. The dotted lines tell you the targets. So the target in the control was 23.4 kilocalories. The target in the experimental was 16.3. So both groups got about 70% of their target. Here's the actual results. There was no difference in the rate of glycemic events outside of the interval of 6.1 to 8.3, so that was the primary endpoint. No difference in that. That's that middle group, middle bar graphs right there. Interestingly, though, there was a significant increase in the mean rate of glycemic events that were between 4.4 and 6.1 millimoles per liter, which is sort of the normal range. This actually concerned the DSMB, and they were concerned about this lower number, and this is what stopped the trial, even though that these are normal glucoses. And there were also significant decrease in values above 8.3 millimoles. So we didn't have any difference in that middle part that we were looking at, but we had fewer events in the high and more events in the kind of normal range. In fact, if you look at the mean glucoses, the mean glucose was significantly lower in the experimental group, 7 versus 7.7 millimoles per liter. There were no difference in the rates of hypoglycemia, defined as glucose is less than 4.4 millimoles per liter. And if you look at that glycemic index or glycemic dispersion, there was a smaller glycemic dispersion in the experimental group. The experimental group also received less insulin, so there was less insulin administered both in the amounts and the number of administrations in the experimental group, and no difference in the amount of rescue glucose that was given, or rescue dextrose that was given. What about tolerance? There was some increased frequency of abdominal distension in the experimental group, but overall the number of patients with adverse events in both groups weren't different. And if we look at a clinical outcome of mortality, mortality in general was low in this trial, but it was numerically lower in the intervention group than in the control group, but not statistically significant. So as a question, why did the patients get better glucose control in the experimental group? And I think there are a number of potential reasons for this, and honestly, I suspect that multiple of these are in play. So it's not just one of these reasons, but it's many of these together. One is that a higher protein load probably improves insulin sensitivity. The second is the type of protein probably matters, and whey protein improves insulin sensitivity. The third is pretty simple. If you give fewer carbs, you probably have better glucose control. Seems to make sense. And in general, if you give fewer calories, you actually have better glucose control. And there's been a number of previous studies, one of which was our previous Eden study where we did trophic versus full feeds. And in that group, fewer calories had better glucose control, less insulin administration. So a summary of Divine: a very high hydrolyzed whey protein, low carbohydrate formula facilitated blood glucose control in critically overweight and obese patients. And although it didn't reduce the number of events outside of the interval of 6.1 to 8.3, it did lower dispersion of blood glucose as measured by standard deviations, and had a lower incidence of hyperglycemia, defined as glucose is greater than 8.3 millimoles, increased incidence of normal glycemia between 4.4 and 6.1 millimoles, all with decreased insulin use and no increase in adverse events. So to conclude, nutritional support for critically ill patients needs to be individualized, and that includes for our obese patients. Current data suggests that moderate permissive underfeeding while administering higher levels of protein may improve outcomes of critically ill obese patients. Avoiding hyper and hypoglycemia likely does improve outcomes, and at least this study suggests that we can accomplish these goals by specific nutritional formulas, but we should do further research to see if these nutritional formulas actually improve clinical outcomes and not just blood sugar control. Thank you for your time and attention.